Hi, good day, and welcome to the webinar. Today's webinar is sponsored by the Medical Association of Georgia, their Indie Practice platform and initiative, and VenOps, which is my company, that does OIG exclusion screening for hundreds of independent medical practices and companies. The title of our webinar today is Why Chronic Care Management and Remote Patient Monitoring Should be Part of Your 2024 Plan. And our main speaker is Ravana Youssef of Elenkos Health. Elenkos delivers industry-leading care management solutions to high-risk, high-cost populations, and they help providers engage more proactively in the care of their patients to optimize patient and practice outcomes. And their website is Elenkos, E-L-E-N-C-H-O-S, health.com. And I read that right off their website. So our second talk, as time permits, will be about remote patient monitoring and why that should be part of your plan too. So now I'm going to turn off my camera. I'm going to give the screen to Ravana. And there we go. It's always a little bit of a hiccup there. And Ravana, the floor is all of yours. And now I can see your screen.
Awesome, wonderful. You can see where my doc says Elenkos Health on here, making sure you have the right screen.
Yeah, I do. You are ready to go.
Awesome, thank you, Mark. I appreciate one, having me on here today. This is really exciting. Love being able to talk about what we do and the difference we've made in the outpatient setting over the last several years. So my name is Ravana Youssef. I am the Vice President of Sales for Elenkos Health. Elenkos is a company that's very, very focused on value-based care. We are a readmission prevention company that has built multiple programs around value-based care. We have collaborated with some of the largest hospital systems, ACOs in the nation, really trying to find the root cause of what is causing our patients to be bouncing back and forth into hospitals, and what we can do as a provider to help minimize or mitigate those. So looking forward to collaborating with you in the near future. But really at a very high level, what is the issue or what is the problem? So we know that we have several million Americans who are chronically ill. And when patients are chronically ill or are diagnosed with chronic diseases, their providers begin to multiply. And when a patient is diagnosed with any type of chronic disease, we know that these diseases are here to stay. They're not going to leave, unless we begin to manage them at a very, very high level. So chronic diseases we know need to be managed for life, but we also know that this is a population or a demographic that may begin to be battling more behavioral mental health, dementia. So there's more underlying issues that the patient could be navigating around. So in order for them to know and understand what's happening within their health, they need some assistance, more guidance, more eyes on their health, and then more assistance in how to navigate through doctor to doctor. One of the biggest things that I've seen with being in healthcare is that while patients do have multiple doctors, most of the time these doctors are not communicating with one another. So Mrs. Smith may be diagnosed with a specific disease, is seeing a specialist for that disease. That specialist may be prescribing a specific medication or a certain medication that maybe her PCP had already began her on to begin managing that disease, but the PCP and the specialist are not talking to one another. So that's where we come into play. That's where we really want to make sure that our care managers are very, very focused on the patient's health as a whole and not just specific diseases or what that provider is managing on that patient. So the Elenkos advantage, or the way Elenkos serves chronic care management, or really any of our value-based programs, is we provide a end-to-end solution. So we approach our practices, we try to find the root cause, or really what the practice is battling within their patient volume or patient base. And if it's compliance, if it's, patients are not responsive, how do we re-engage our patients, and what do we do to have them really manage their treatment plans or their patient plan of care in between their office visits? So we walk into practices as long as, this practice does have an EMR. All of our care managers, we have about 150 care managers across the nation that do work remotely. So an EMR is a must. We cannot be working with practices that have patient files because we just won't be able to know or understand what's going on with their patients. We run an EMR analysis to really understand the patient base. How many patients qualify? How many are Medicare, Medicare Advantage? What are the chronic diseases that these providers are managing or seeing come into their practice? And where can we come in to add value there as well? So we really like to focus on our disease-specific assessments. So if patient A, Mrs. Smith is diagnosed with chronic heart failure, and patient B is, let's say, a diabetic patient. When we're assessing these patients and really putting them through the patient journey, these assessments are completely different. They're disease specific. So patient A and patient B will not be going through the same assessment as we're trying to identify what these patients are really encountering in between their office visits. As these patients come into their visits, we want to make sure that they remain compliant and returning back every 4 to 6 months to ensure their medications are reconciled, to ensure that the PCP or whichever provider we are servicing is staying on top of this patient's plan of care. The moment or the second the patient begins to fall off their, let's say, their office visit schedule, that's when patients begin to decline. Medications are taken at their convenience or on their schedule. They seem to forget what they need to take, how to take it. So our care managers really play a vital role in the patient's journey, ensuring that they're constantly reminded of what needs to be taken, how it needs to be taken, if there's any follow-up appointments or referrals that these providers are sending these patients to. Our care managers play a very, very high role in ensuring we can have transportation scheduled. We're reminding these patients, we're giving them a call and doing, a courtesy reminder call of, hey, Mrs. Smith, don't forget you have a lab appointment tomorrow. Make sure you go in. Is your transportation ready to go? Do you have a ride? So they really play more of a personal assistant to the patient's health, ensuring that this patient has a go-to person 24/7, even during holidays, after hours, weekends, you name it. These care managers are readily available for these patients to lean on as they need or as things arise in between their office visits. This gives you a very high level view. I get asked all the time, or I get told at least all the time, but I can just do this within, my office. I have staff that are here every day. That's very true. You definitely can. But at that time, when you have when you have staff members that are in your office and patients are coming in and out the door, your focus is really taking care of the patient that's in-house, that's in the facility or in the practice at that time. Whereas our care managers are touching hundreds of patients in just one day, where you might have 1 or 2 staff members dedicated to this. So we really do have a higher volume that we're touching on a day-to-day basis, ensuring that when your staff and when your providers are in your practices, you're really focused on that patient face-to-face, while we can focus on your patients that are at home that may be needing you, but we can help triage accordingly to whatever is arising at home. It's also a very heavy lift on the practice. There's definitely a lot of documentation that goes into chronic care management, and even technology. So our technology is built to track minute by minute when we are servicing our patients or caring for our patients. And we're able to document everything that is being cared for or being assessed during the patient's call. In addition to that, we also have a platform that really helps build a very hefty and complex care plan that really just brings everything all together as far as the patient's health is concerned. So when the patient is seeing multiple providers and these providers are not talking to one another, our care managers are doing the due diligence of reaching out to these providers, collecting the last office visit notes, building a very nice care plan for our providers that we can put together into a 2-3 page summary and uploading this care plan into the patient's chart in the EMR. That way, when Mrs. Smith comes back and, doc is ready to see Mrs. Smith, he pulls up her chart, can see all the care plans on this patient, and really has a very high level view of what's going on with the patient in between his visits and really what's going on with the other physicians outside of his practice. We focus on medication therapy management. We also heavily focus on closing care gaps to help the practice and also help the patient stay in compliant with their testing and examinations on an annual basis. Here you'll see also a very high level view of what happens on a month-to-month basis. Not every month is a patient contact month, meaning we are not calling patients and bothering them every single month. On the first month, this is where we educate the patient and really build a value on the program that this practice is providing or the initiative that this practice has taken to really care for patients in between their office visits. So here we're really going over assessments, we're reviewing any upcoming or past appointments, we're asking the patient if there's been any recent hospitalizations and what may have caused that, and really just going through the patient's PHI, introducing them to chronic care management, what that journey is going to look like for the patient as they go through the program, and really collecting the consent. So the biggest piece of this program, and really sometimes the hardest piece on the practice, is collecting that consent, building the value on the program, and really expressing to the patient why this is a really good journey for them to be on to ensure that they're safe and healthy at home as well. Once a consent has collected, the patient no longer goes through what's called the onboarding process. So that initial month is a patient contact month, of course. After that, they go into month 2, which is care coordination. Here, our care coordinators are calling all of the other providers outside of the practice that we are servicing and collecting all of the last office visit notes to really know and understand what's going on in between these office visits outside of our practice. This is not a patient contact month, although we do like to educate the patient by sending them a mailer and letting them know what their care manager worked on this month. Again, if the patient needs to contact their care manager, regardless if it's a patient contact month or not, the patient can reach out to their care manager. They will have a direct line. They can be reached via phone, and we do also have a text messaging option as well if the patient is savvy and would rather just send a really quick text. It does go through a very HIPAA compliant platform, so we want to make sure that that is all safe within both platforms between the patient and the care manager. Month 3 is also another non-patient contact month. Here, this is typically a pod of a pharmacist, our pharmacy technicians, and what they're doing is they're calling all of the pharmacies this patient goes to or refills their medications at, and really building a care plan and a drug interaction table that shows all of the recent medications this patient is taking and is truly taking, right? So if something was prescribed this month, patient has never picked it up, that really alerts us that, Mrs. Smith is not taking her blood pressure medication, which is why there's, a few exacerbations happening at home with her blood pressure skyrocketing. So those are conversations that we can have with our patients, and then also keeping our providers up to par on what's happening at home. So they're building this treatment plan around the medication, building a drug interaction table, ensuring that this patient isn't taking, any 2 drugs that may interact or cause any serious damage to the patient's health. And we're conveying that information over to all of the providers and the patient as well. The 4th month and the final month of the journey, and then every month after that, is our follow-up month. So here we are reaching out. This is our disease-specific pod, typically made up of our medical directors. So we have providers, we have registered nurses, we also have pharm techs and medical assistants that are really reviewing the patient's care, all the care plans that we've built over the last 3 months. And here we're contacting the patient, checking in to see how they've been doing over the last 6 to 8 weeks, ensuring that nothing has arose over the last 3 months. And if so, if there's a new medication, if there's a new provider, if there's unfortunately a new disease they've been diagnosed with, then we're really making sure that we're building the patient's portfolio with our provider. So everyone that is in touch with this patient's care is all on the same page. So every month, the patient is going through the journey after onboarding. So they'll go back to care coordination after follow-up, and the journey essentially continues. Again, patient is reached out to every 6 to 8 weeks, but patient has direct contact with the care manager whenever they want. That means it's every day, then we're here to assist the patient every day if that's what they need. And here is what our care plans essentially look like. I think one thing to note here as well is that your patients will never know who Elanco is. We integrate ourselves within your practice, and we will always call the patients calling from Dr. Smith's office or whoever the provider is, or whatever the practice name goes by. Anything we send out as far as mailers or care plans will also be white labeled to the practice name. So really the only people that will know who Elanco is us as the entity and the practice that we partner with. We've learned that patients are, especially this demographic, they're very, very highly targeted with scams. And them knowing that their personal provider has taken an initiative to provide additional care and extra set of eyes from within their practice really goes a long way. It builds a greater sense of value and a greater sense of trust within the practice. So we always want to showcase that this is coming from the practice itself and not from a third-party vendor that's providing these services. That's all I have, Mark.
Well, thank you, Ravana. That was fantastic. Let's see here. I think there's a couple of questions in the chat.
Sure.
I got a couple of questions by text here. So I'm going to leave your screen up here for just a minute. And so is it, as far as the practice is concerned, is it really hands-off for them? They always, they're generally overworked and understaffed. Just ask anybody. Is it really hands-off?
Yeah, so that's a really great question. So the way this program is built, and I think what's really important for me to share is we're one of 2 companies in the nation that's directly contracted with Medicare. So what does that mean? It means we do all of the billing. We do everything from running analysis to your EMR, pulling or extracting the patients that qualify. And how does a patient qualify? So a patient has to have 2 or more chronic conditions. They must be seen with the provider that we are servicing within the last 12 months, and they must have some type of active insurance that covers this program. So our admin team or our operations team is really deep diving into your EMR, extracting that list of patients, and then I come and present it to you and say, hey, Dr. Smith, these are the patients that qualify. We're going to begin onboarding these patients. We are collaborating with the practice. We're collaborating with the physician. So I can't sit here and say that our program is completely rolled out the same exact way across the board, because it's not. Some practices have a little more expectations. Hey, please make sure that you guys are also scheduling appointments. Great, we can do that. I have other practices that say, hey, I want you guys to do everything from start to finish as far as chronic care management is concerned, but our scheduling is a little wonky. Every provider schedules a little different. So if any appointments arise while you are talking to the patient, just send my staff here in this pool or via EMR a message that Mrs. Smith needs an appointment on this day at this time. So as far as hands-off goes, it's as far as a program, yes, we don't need anything from the practice as far as us being able to service a patient, but there will be questions that arise. We don't review labs, so anything more clinical, we really want the practice, the staff, the MAs, or even the providers to be highly engaged with that. So what we assist with is if, a practice, in order to review labs, you have to schedule an appointment. We'll be scheduling that appointment for the practice, but we make sure that the labs are being reviewed and addressed at the practice level.
Got it.
If it's, let's say, prescription refills, we don't necessarily submit them to the pharmacy ourselves, but what we do is we collect all the information just as the front desk receptionist would. We'll send it over to the provider, and the provider just needs to approve the refill, and then out it goes to the pharmacy.
That sounds good. So it sounds like you stay in your lane, but for everything you do makes it pretty hands-off in the practice, except for the clinical component, which I'm sure is what they would prefer anyway. So Once a practice decides that they want to engage with Elenchos, can they get up and going within a month?
Yeah, so typically, yes. I guess a couple things happen before then, right? So let's say they like the program, they want to roll it out. In order for us to serve as one family, we all need to know how each other essentially operates. So what I like to do is I set up a virtual call, typically with practice managers or administrators, whoever really is running the practice or the operational portion of the practice as a whole, and they meet with my operations team. Because in order for my care managers to serve as an extension to the practice, they have to know how this practice also operates. So we ask questions from what's your fax number to, hey, if a patient called us and said they no longer are taking this medication, do you want us to go into the EMR and discontinue this medication? So really, I like to tell the practice managers, train my team as if this team was working in your practice. That way, once we launched a program, it's seamless. So we do what's called an implementation. Then I come back and I teach, Dr. Smith's office who Elenchos is. That way, when patients are calling just to double check of, hey, Ravana called me from your office. She stated she's your care manager. Can you please confirm that I want to make sure this isn't a scam call? It really just takes one front desk receptionist or an MA to say, yeah, I have no idea who that is, for the patient to feel a little weary. So we have to know who each other are. That happens prior to launch. After that, we're requesting login. So every care manager, every operational team member, and then our IT team will have an EMR login. That way we can run an analysis and we can begin the launch of the program and start mailing out mailers that introduce the program from the practice's standpoint. We also, what we like to do within each practice is we like to credential at least one provider from that practice to our PC. Since we do the billing, so our model is we do the billing and we reimburse the practice per patient service per month. But one thing that we like to also have is one of the providers within the practice credentialed within our PC. One, to make the billing a little more seamless because of state laws and just credentialing within each payer within the states. But more importantly, what it does on a patient point of view is once they identify, Dr. Smith on the EOB, they know where it's coming from. They know what this service is for. If they see one of our providers on the EOB, they sometimes questions start to arise of who is this? I don't know this provider. So just to make it a little more seamless, we like to always have at least one provider within each practice credentialed within our PC. After that, we are ready to launch. So yeah, launch happens fairly quickly once these kind of prerequisite items are completed.
And what's the smallest and what's the largest practice that you've engaged with? And is there an ideal specialty, medical specialty or subspecialty?
Yeah, great question. Smallest practice, I would say, is around maybe 130 Medicare patients. Keep in mind that this changes, right? We run analysis on a monthly basis because we know that patients are getting Medicare on a day-to-day basis. We also know that patients may have come back for their annual visit. So now that visit within the 12 months is now populating, right? So patients can drop off because they haven't been there in 12 months, which will help the practice in scheduling those appointments. Or people come on board or are now eligible because they have Medicare. So that number can fluctuate. So the smallest I would say is about 130. The largest is about 10,000 patients. So we are able and have the capacity to service anywhere between those two numbers, and as you can see, it's a wide range of it. As far as, I'm sorry, the second part of your question, specialty. So specialty, think chronic conditions that are here to last until the patient's death, unfortunately. So a dermatologist wouldn't necessarily be one, although they may assist in skin conditions or skin diseases, they're not diseases that need to be managed on a day-to-day basis or a week-to-week basis. So think cardiology. Right now we're servicing pain. We have interventional neuro management as well. PCP, of course, general practice, family practice, those automatically qualify. We also have anywhere from, let's see, cardio, pulmonary, geriatric. So really just think of any specialist that is monitoring these patients on a 3 to 4 month basis with diseases that could cause this patient to bounce in and out of the hospital.
Got it. What about orthopedics?
Orthopedics do not qualify. They are more obviously focused on the bone structure of the patient's health. So they don't necessarily qualify because they're not essentially managing a chronic illness. In a sense, so I know they typically can manage pain, but they're not managing an illness that's requiring a patient to take medications or to have any type of monitoring devices on them. So when we look at these high-risk patients, we really focus on what's causing them to, bounce into the emergency room, and is it something that we could have caught ahead of time with any subjective or objective matter. So that's what we typically focus on.
And last question is one on security with offsite access to the EMR and so forth. I know that you have a business associate agreement. And what about other security concerns?
That's a phenomenal question. We have a large compliance team that not only monitors our care managers' calls that are being recorded in their laptops, but our IT team has set up a very, very secure system within each laptop. So prior to these laptops going out to our care managers, they go through a very high security system that is downloaded into these laptops where we can monitor very, very closely. So we ensure that, compliance is a thing, and we make sure that, all HIPAA guidelines are being met. At any time that we feel that this isn't, action is taken, and it's typically serious action that is taken. Granted, I haven't seen this happen within our company. Thankfully, our care managers know and understand the importance of keeping everyone's information at a very secure level. But they have all gone through HIPAA certification. They all have a very secure system within their laptops that could be monitored from, a very high level of even just turning on my laptop, and I can, go into one of my care managers and ensure that what they are doing is within HIPAA guidelines as well.
Fantastic. And if anybody wants more information, they can reach out to us here at info@venops, that's spelled VENOPS.com, or you can, of course, contact Ravana directly, and her email is a little longer. Why don't you spell that out for everybody in case they want to contact you directly?
Yeah, of course. So my email is RYOU, S as in Sam, IF as in Frank, at elenchos.health.com. So that's ELENCHOS health.com. Please also feel free to reach out to me via phone. My phone number is 586-246-8985. Happy to also set up a virtual meeting for a more in-depth presentation if you'd like.
Great. And although the original title of the webinar was Chronic Care Management and Remote Patient Monitoring, we'd like to keep these to 30 minutes. So we've actually used up most of our time on this very interesting subject of chronic care management, which is perhaps a little bit more applicable to more practices anyway. And I'd say the biggest difference between chronic care management and remote patient monitoring is that chronic care management doesn't involve any monitoring equipment. There's nothing sent to the patient's house in the way of equipment, or like a pulse oximeter or blood pressure. And we've done that in the past, had a webinar on that, and we'll reschedule one for the future to get into that a little bit more in depth. And so with that, I will end my my part of this. And Ravana, I'll give you the last word to say bye before we say happy Easter and a happy holiday weekend to everybody.
Yeah, no, I appreciate it. It's coming by very, very fast. Hopefully the warm weather is upon us as well. But thank you so much, everyone, for your time, and Mark for having me today. I enjoyed this conversation. Thank you so much.
You're very welcome. Have a great weekend. Thanks for joining.
Thank you.